have a younger athlete that is in high school. He has bilateral knee pain, so knee pain on both sides, and he doesn't have a specific like mechanism of injury. Like he doesn't know like, hey, it happened when I did this versus this. So I'm asking questions like that's pretty much trying to differential diagnose what kind of knee pain he's having. So my question is, how do we go about differential diagnosis for the knee?
Gotcha. So when I was at your stage, I would have been hyper focused on the knee, like what is wrong with the knee, and give me an answer. Is it a meniscus tear? Is it patellofemoral pain syndrome? I need a name. Somebody tell me what it is. But I quickly found out that it didn't matter if it was an ACL sprain, if it was a meniscus tear, if it was a quad strain, if it whatever it was, it didn't matter. I was going to treat it somewhat similarly. Of course, take this as a simple example. It always depends most of the time. But now I take a step back and I'm like, well, if he's not really complaining about stuff you kept asking about over multiple visits, let me step away because it might not be a knee problem. It might just be, or I should say, it's presenting in the knee. It might be coming from, who knows, it could be coming from the lats on the opposite side. So then I start to say, well, let me just look at everything and test everything within reason and see what deficiencies he has. I think we did a video where I told you when you first started, there was a track athlete with like a bunch of lower extremity problems, and he had this hip pinching, and I didn't figure out the hip pinching until like his fifth, sixth, or seventh visit. Because even now, still, I'm like, well, you came in for the ankle and the knee. Let me check all that. Even though he did complain about the hip, I just took a step back and analyzed everything. It happened to be when I checked his abdominals, did some testing for that and exercises for that. His hip pinching went away, then his knee got better, and the ankle issues on the opposite side got better too. So in this person's situation, if he's like, I don't know where it came from, my knee's just hurt, well, let's check everything, and that's how I differential diagnose.
So I did his eval last week. I did manual muscle testing. I did range of motion, all of those things, and I found that he had weak. Well, in comparison to other parts, he had weak hips, weak glute max. So you're saying, kind of going forward, I should pretty much base a lot of my treatment based off of my findings.
Right. So you found where the possible inhibition was, or reciprocal inhibition was. Then you treat that, you facilitate it, you fix that inhibition, you make it work right and do what it's supposed to do, and you continue with it, and you'd